This conference will now be recorded.
Today's topic is burns. Burns are the wound caused by the exogenous agent leading to coagulative necrosis of the tissue. Causes of burns can be thermal burns, chemical burns, electrical, cold burns, and radiation induced. Thermal burns can be dry heat and moist heat. Dry heat are contact burns and flame burns, whereas moist are scalp burns. Smoke and inhalational burns also come under thermal burns. Chemical burns can be because of acid or alkali. Electrical burns can be high voltage or low voltage burns. Cold burns example is frostbite. Am I audible? Thermal burns. It is nothing but heat exchange. The molecules of the structure of the tissue get destroyed and there will be denaturation of the proteins. The extent of burn injury is depend upon the temperature of the agent and amount of heat and duration of the contact. The effects of burns are influenced by intensity of the energy and duration of exposure and type of tissue injured. Pathophysiology. Generally, because of burns, from the burn area, there will be heat loss and there will be inflammatory mediators come to the burn area, which lead to the vessel dilatation, and there will be increase in the capillary hydrostatic pressure and permeability, which leaks the plasma from the intravascular into the interstitial space. Because of this, there will be edema. And third space fluid loss also will be seen, and there will be associated fluid and electrolyte and acid base imbalance will be seen. And in the first 24 to 36 hours there will be hemoconcentration. Later the fluid will remobilize into the vascular space, and this fluid shift will restore the fluid and renal perfusion will be restored. And increased urine formation and diuresis, continued electrolyte imbalance. Hyponatremia and hypokalemia um, is because of the hemodilution. Systemic causes of burns, cardiac, there will be decreased cardiac output because of third spacing of fluid. And in case of pulmonary, there will be respiratory insufficiency, which will lead to respiratory failure and aggressive pulmonary toilet, and oxygenation will lead to improve the lung function. And gastrointestinal, there will be decreased or absent mobility. So we should feed the patient by giving the through NG tube when the total body surface area of burns is more than 20%. Curling ulcer formation. In case of head injury, that is Cushing ulcer, and this is Curling ulcer. Head injury Cushing ulcer is because of decrease in acid output, whereas Curling ulcer formation is because of the mucosal deficiency. It is the acid output in Curling ulcer is normal. Metabolic. The burn patient will have the hypermetabolic state, so there will be increased oxygen and calorie requirements, and the core body temperature also will be increased because of hypermetabolism. Immunological. The burn patient will be immunodeficient, so they will be more susceptible for infections. Body response to burns. There are 4 stages. First is emergent phase. This the pain response, like there will because catecholamine release, and this leads to tachycardia, tachypnea, mild hypertension, and mild anxiety. Second phase is fluid shift. In the first emergent phase, it lasts for 18 to 24 hours. After that, this fluid shift phase begins, and it reaches the peak at 6 to 8 hours. Damaged cells initiate the inflammatory response and shift of the fluid from the intravascular into the extravascular space, which lead to massive edema. Hypermetabolic phase, it is stage 3. It lasts for days to weeks. Large increase in the body needs for nutrition as it repairs itself. In this hypermetabolic phase, resolution phase, it is nothing but there will be formation of scar and general rehabilitation and progression to normal function. And Jackson's theory of dermal wounds. This is zone of coagulation. Next is zone of coagulation is when the direct injury to the tissue. Zone of stasis is surrounding the zone of coagulation, and zone of hyperemia is next to the zone of stasis. In case of zone of coagulation, the tissue is irreversibly get destroyed already. In case of zone of stasis, there will be partial viable tissue and partial coagulated necrotic tissue will be seen. In case of zone of hyperemia, there will be increased blood supply. So the zone of stasis, either it will progress into the necrotic tissue, or it will repair by its own by the treatment. Zone of coagulation. This is area in the burn nearest to the heat source and suffers the most damage, and it is irreversible tissue damage, and this is the area of necrosis, zone of coagulation. Whereas zone of stasis, the area surrounding the zone of coagulation, characterized by decreased blood flow. If you treat properly, the blood flow will be increased and this area will be regained. If not, if we are not treating properly, then the blood supply decreases and it will also go into coagulate to necrosis. So it either survives or go into coagulate to necrosis. Because of this, John, we should avoid cold water, because cold water will causes vasoconstriction and it further decreases the blood supply and the tissue will go into coagulate to necrosis. So that's why we should prefer tap water. Zone of hyperemia. The peripheral area around the burn which is having the increased blood flow. This is zone of hyperemia. Severity is determined by the depth of wound and the extent of the burn, calculated in the percentage of total body surface based on the location of burns and patient risk factors. Classification of burns. First degree burns. This only epidermis is degree. There are two types, superficial and deep. In case of superficial, up to papillary dermis, there will be involvement. In case of deep second degree burns, up to reticular dermis, there will be involvement. In case of third degree burns, there will be full thickness injury. So there will be involvement of dermis, epidermis, dermis, and subcutaneous fat will be involved. In case of 4th-degree burns, the injury through the skin and subcutaneous fat along with the involvement of muscles and bone will be involved. Superficial burns. First degree burns. In case of superficial, the examples are sunburns and minor scalp burns from the kitchen. So there will be reddening of the skin and there will be pain, but there will be no blister. It blanches on to touch. And they will have the intact epidermis, epidermal barrier will be seen. It involves only epidermis. So in this, the treatment will be aimed to comfort the topical soothing agents with and NSAIDs. Partial thickness burns. These are second degree burns. Partial thickness, it only involves the epidermis and papillary layer of dermis. So there will be spares the hair follicles and sweat glands. It will be erythematous, blanched to touch, and there will be blisters. And this is very painful. And there will be, in case of superficial burns and partial thickness burns, in both there won't be any scarring. Spontaneous reepithelialization occurs between 7 to 14 days. Examples are scald injury from overheated water tub and flash burns, flame burns. Deep second degree burns. Injury to the deep layers of dermis, like reticular dermis, will be involved. In case of superficial burns, there will be erythema and pain will be seen. And there will be no blisters and it will blanch on touch. In case of superficial second degree burns, there will be pain, there will be erythema, and it will also blanch on touch, but there will be also blister. In case of deep second degree burns, the wound appears pale and molted, and it doesn't blanch onto touch. and capillary return will be sluggish or absent. And it is here there will be pinprick sensation will be seen in superficial and superficial burns and superficial second degree burns. There will be pain. In this, there will be pinprick sensation will be seen, and the two will blanch to touch. But here there won't be, it won't blanch with touch. And deep second degree burns, it will be pale and molted appearance will be seen. And superficial second degree, it takes 7 to 14 days to heal. In case of and superficial second degree, it will heal without any scarring. Whereas deep second degree burns, it will take 14 to 35 days to heal by reepithelialization, and it will have severe scarring will be seen in case of deep second degree burns. And there will be formation of contractures will also be there. So in case of these burns, we will excise the contractures and we'll go for skin grafting. And full thickness burns are third degree burns. Here all the layers, skin along with subcutaneous tissue will be involved. So here there will be dry leathery eschar formation. In case of deep second degree burns, how the wound appears? It appears pale and molten. In case of third degree burns, it appears dark, dry, leathery eschar will be seen in case of third degree burns. And in case of deep second degree burns, there will be pinprick sensation. Whereas in full thickness burns, there will be loss of sensation. So all dermal layers are involved, and reepithelialization should occur from the wound edge. So we have to excise the scar, and then we have to excise the burn area, and then we'll go for skin grafting. Fourth degree burn, it involves the structure beneath the skin, muscles and bones. Assessment of burns. It can be assessed by rule of 9, which is used to measure the large surface areas, and we can assess the extent of burn. In case of males, in case of adult, the head and neck covers 9%, front 18, back 18, both each leg 18, limbs upper limbs 9%, and perineal area 1%. In case of child, this rule of 9 is not that much accurate. So the head and neck covers 18%, front 18, back 18, each leg 14%, in each arms and upper limbs 9%. So we'll go for Lund and Brody's classic rule to assess it is more accurate in case of children to assess the extent of burn injuries. Rule of palm. It is only used when the surface area when there is any splash injuries, or when there is mixed injuries. Then where the palm is we use patient's palm. We have to cut a paper and measure the patient palm, and with that we should measure the area. One palm area is equal to 1% of body surface area. Generally, it is used in case of less than 10% of the total body surface area. Management of burns. In case of burns, first pre-hospital care. We should shift the patient to secured safe area, and stop the burning process by wrapping in a blanket, and pour the warm water, not warm water, tap water should be poured. The ideal temperature of the water should be 15 degrees, and we should not use cold water because it will lead to vasoconstriction, which further decreases the blood supply to the wound, and which will lead into the coagulative further damage to the tissue. So never use cold water in burn patients. We should use normal room water temperature like tap water, or 15 degrees water is the ideal. And it is only effective till 1 hour, and we should pour the water for 10 minutes. Then check the other injuries, like we should check for any airway, breathing, circulation should be checked rapidly, and then we have to go for secondary survey. Inhalation injuries, we should give 100% oxygen. Room temperature water should be poured to decrease the depth of the wound. Hospital cares. Then after coming into hospital, same A, B, C, D, E, F. Airway, breathing, circulation, disability, and exposure with the environmental control and fluid resuscitation. Secure airway and ventilation. Generally, we should go for ventilation when direct intubation of the patient. When there is any history of inhalation of superheated air or soot around the mouth or nose, grayish or blackish sputum, and singed nasal hair, burns to the lower face and neck, stridor, hoarseness, dyspnea, and persistent hypoxia. In case of because of this, there will be involvement of upper respiratory airway, which will lead to the laryngeal edema. Later, we cannot intubate this patient once the edema is developed. So, before the hand, we'll intubate the patient. If already edema is developed, and the patient is going into respiratory failure, then we have to go for cricothyroidectomy. And in case of full thickness burns, circumferential burns of the chest wall, even if you are giving the ventilatory support, but the patient saturation will be low. Because of this, the chest cannot expand because of the circumferential burns of the chest wall. So we have to go for escherotomy to release the pressures, and there will be adequate chest movement. Supplementation of oxygen. Nasal cannula in case of majority of the burns patient we have to keep, and 100% oxygen should be given in case of respiratory inhalational and carbon monoxide poisoning. Circulation. We should keep the IV lines. Two broad IV lines should be kept. First preferred is the hands, then antecubital fossa should be preferred on neck. If it is not possible, before going for the central line, we have to keep the venous cut down, and then we have to try for the cannulation of the saphenous vein. If it is not possible, then we can go for central line. We can keep IV cannula even in the burned areas. Only if it is edema, if it is not possible, then we have to prefer other areas. Escherotomy of the limb. If there is eschar formation, below the eschar, the tissue will be edematous, and there will be increase in the pressures in that compartment. So there will be decrease in the circulatory circulation to that limb, which will lead into the gangrene of the limb. So we have to go for escherotomy and release the pressure. Sclerotomy, we have to incise the skin, superficial fascia, deep fascia, and the muscle will bulge out. So the pressure will be released and the circulation will be regained. Fluids for resuscitation. In children with burns, over 10%, generally we should start fluids when the children of burn area more than 10% of total body surface area, or adults of total burn surface area is 15%. We should give IV fluids. Most, if it is not indicated, then oral fluid should be used. Salt should be added in the oral fluids. Fluids needed can be calculated from the standard formula. And the key is to monitor the urine output. Parkland's formula. Volume is 1%, volume of the fluid should be given is equal to the 1% of total body area burned into weight in kgs into 4 ml per kg. This should be given, this is only for 24 hours, first 24 hours, and it is only used for colloids. Sorry, it is only used for crystalloids, not colloids. So total body surface area burned, if it is 50% and weight of 50%, it will be around 10 liters will be there. So first 5 should be given in 8 hours, and next 16 hours, next 5 liters should be given. And this will start when at the time of incident of burn, not when the patient comes to the hospital. At the time of incident of burn itself, the for this Parkland formula, we should calculate the fluids and we should give within 24 hours. And the second day, how much fluid we should give? The fluid should be half of the first day volume. Like if we are giving 10 liters, second day we should give around 5 liters. The fluid of preference in case of burn patient is ringer lactates. Other fluids we can use normal saline, hypertonic saline, and human albumin solutions can be also be used. Colloid solutions like plasma, hetastat, and dextrans can also be used. And the commonest colloid-based formula is Murray and Berkeley's formula, which is 0.5 into percent of the body surface area burnt into weight. It is equal to 1 portion. So the periods we should divide either 4, 4, 4 or 6, 6, 12, 12 hours. So 1 portion should be given in each period. And both colloid and crystalloid based formula is Brooks formula, where the colloid should be given 1.5 ml per kg of total body surface area, plus colloid should be given 0.5 along with 1.5 plus 0.5 per kg per total body surface area plus 2 liters of free water should be given in case of Brooks. It is both colloid and crystalloid based formula, but Parkland formula is the most commonly used formula. And in case of children, we will use Galveston formula. Assessment of adequacy of fluid output. Anywhere the fluid urine output will indicate the tissue perfusion. So fluid requirement will be based on the urine output. The minimal urine output should be more than 0.5 to 1 ml per kg per hour in case of children, and in case of adults it should be more than 1 ml per kg per hour. And we should also place in burns patient central venous CVP to measure the adequacy of the fluid, because if we over hydrate the patient, it will lead to further edema and there will be further complications. So the CVP should be maintained 5 to 10 centimeter per water. And in case of urine output more than 2 ml per kg per hour, it is a sign of overhydration and we should decrease the fluids. Fluid osmolarity is also most accurate parameter. But in clinics, we'll use mostly the urine output will measure and CVP will see. Ascherotomy. When there is a circumferential injuries, that too in deep second degree and third degree burns, because of the underlying tissue edema, there will be pressure in that compartment of the limb. So the peripheral circulation of the limb will be compromised. So there will be symptoms like numbness and tingling and increased pain in the digits. And arterial flow should be checked by using Doppler. And we should also see for capillary refill time, tissue pressures. And tourniquet effect of the injury is easily treated by incising the whole length of the full thickness burns. Ascherotomy should be done. Incise longitudinally along the medial or lateral surfaces. Completely relieve the impediment of the blood flow. Debridement. When there is after formation of the necrotic tissue, generally we will debride. Types of debridement or auto debridement, we can go for tangential at the end of first week. And staged primary debridement. We'll debride the dead tissue and wait later by stage wise we'll debride. For the deep circumferential burns, we have to go for ascherotomy. Analgesics. In case of small superficial burns, simple oral analgesics or topical cooling agents will be sufficient. In case of large burns, intravenous opioid should be given. Continuous analgesics are required in the beginning with infusion and continuous with oral tablets such as slow releasing morphines. Nutrition. Already we discussed that the burn patient will be having the hypermetabolism. In case of burn patients, the requirement will be increased because of hypermetabolic response, catabolism of protein, and decreased lean body mass. Because of this, we should give the patients extra feeds. And mostly, there will be curling ulcers, so we should give sorry, PPIs, proton pump inhibitors for the ulcers, and also the nasogastric tube should be placed if the total body surface area is more than 20%. Total burn surface area is more than 20%. And the how much calorie requirement should be given is 25 kilocalorie per kg per day. Along with, we should also add 40 kilocalories percentage total body surface area per day, because there will be increased requirement of the nutrition to the burn patients because of catabolism of proteins, hypermetabolic response, and decreased lean body mass index. In case of burn patients, we should also give tetanus prophylaxis should also be given. Tetanus toxoids, 0. If the patient has taken more than 5 years of a booster dose, then we should give 0. 0.5 ml of intramuscular before should be given. If immunization status is not known, then tetanus immunoglobulins of around 250 to 500 units intramuscular along with tetanus toxoid to the opposite side should be given. Monitoring and control of infection. Burn patients are immunocompromised. All because of cell-mediated and humoral mediated cells will be there will be immunocompromised state, so there will be more chance of infection, and so we should take a very strict sterile precautions, and swab should be sent regularly. And in case of burn patients, there is the most common infection is pseudomonas. A rise in white blood cell count and thrombocytosis and increased catabolism are warning signs of infection. Topical treatment of the burns, deep burns. What are the different topical agents we should use? Will use in case of burn patients. 1% silver sulfur diazine cream, which is this is most commonly used, and it is a broad spectrum antibacterial, and it is acts against the pseudomonas, which is the most common infection in case of burn patient, and also an MRSA. 0.5% silver nitrate solution. It is both broad spectrum antibacterial as well as silver nitrate is antifungal. So but the main disadvantage is there will be black staining will be seen in case of silver nitrate. And mefenamide acetate cream. It is most commonly used in US. Mefenamide acetate cream, it will be painful on application, and also it will causes metabolic acidosis. Bacitracin, polymyxin, neomycin, it can be used for superficial partial thickness of facial burns, and the risk of MRSA is there, then we can use mipirocin. But most commonly used agent is 1% silver sulfur diazine cream. It is systemic absorption will be less, and it is easily and cheaply available in the market. Principles of dressings. There are two types of dressings. Either we'll apply the cream and leave the patient, apply the cream and we will dress on that. So this is one is open exposure and closed dressings. And in case of full thickness and deep dermal burns or antimicrobial dressings, we should do this closed dressings to delay the colonization prior to the surgeries. In case of superficial, will heal and need simple dressings like just we should apply the antibacterial creams and we should leave. Mostly we'll use in case of face and neck burns. An optimal healing environment can make difference to outcome in borderline depth burns. Surgical treatment of deep burns. Early debridement and grafting will be effective because the scarring will be better if we debride early and do a skin graft as early as possible. Like after the patient got resuscitated from the burn injury, then we have to take into the operation theater for debridement and grafting. Deep dermal burns need tangential shaving and split skin grafting. All but the smallest full thickness burns need surgery. Should be ready for significant blood loss. Topical adrenaline will reduces the bleeding. All burn tissue need to be excised. Proper dressing should be done. Post-operative management requires careful evaluation of the fluid balance and level of hemoglobin. Physiotherapy and splinting is important in maintaining the range of movement and reducing the joint contractures. It's also important. After treating the burn patient, we should give a proper post-op care for the burn patient. So we should give the physiotherapy, proper physiotherapy and splinting. So the joints won't go into contractures and the range of movement will be improved. Otherwise, there won't be no use if we won't treat properly post-op with physiotherapy and splinting. Delayed reconstruction of burns. Eyelids must be treated before exposure keratitis arises. The transposition flaps and jet plastics with or without tissue expansions are useful. Full thickness grafts and free flaps may be needed for large and difficult areas. Hypertrophy is treated with pressure garments and silicone patches for around 6 to 18 months. Pharmacological treatment of each is important. Wound coverages. After the burn wound got granulated, we can go for split skin graft. Or if it is a wide area and the split skin graft won't be enough, so we should mesh the split skin graft and then we should apply in that area. In case of face and ears, because we know the split skin graft won't be cosmetically better, whereas full thickness graft is cosmetically better. So in case of face and ears, we should go for full thickness grafts and flaps because cosmesis is very important in case of face and ears. Electrical burns. Electrical burns can be low tension injury and high tension injury. Low tension injuries are like electrical appliances. So the voltage will be less than 1000 volts. Here there will be entry wound and exit wounds. In case of low tension injury, the tissue damage won't be that significant. In case of high tension injury, it will be more than 1000 volts, and the patient will go into tetany in case of high tension injury, and the patient is not able to leave that source of source. So, because the patient is going into tetany. The greatest heat occurs at the point of high resistance. When the current is flowing through our body, there will be increase in resistance. Where the resistance is more, there will be wound formation. So there will be entry and exit wound. It is resistance is more at this point. And dry skin will have greater resistance, whereas wet skin will have less resistance. Longer the contact, greater is the potential of injury. Smaller the point of contact, when more is the concentration of energy and greater the injury. Results. There will be serious vascular and nerve injuries will be seen, and the patient will go into immobilization of the muscles, nothing but tetany if it is a high voltage current. And flash burns, there will be cataract, progressive demyelinated neurological loss will be seen. Once the patient come to us, we should assess for entry and exit wounds, remove the clothing, jewelry, leather items, and treat any visible injuries. In this path, the heart will also get involved. So after coming into our clinic, we should do ECG to look for any bradycardia, tachycardia, ventricular fibrillation, and asystole. Treat cardiac and respiratory arrest by aggressive airway ventilation and circulatory management. Consider fluid bolus for serious burns of 20 ml per kg. Consider sodium bicarbonates. And generally, when the burns passes, this there will be muscle damage. Because of that, there will be release of myoglobin. This myoglobin will deposit in the renal tubules and will lead to the renal failure. To prevent this, we should give mannitol in the burn patients. Any doubts?